Something is happening right now inside the feet and legs of millions of Americans over 50, and most of them have absolutely no idea. No pain, no visible wound, no alarm going off. Just silence, while nerve fibers slowly lose their ability to feel, and the small blood vessels that keep your tissue alive begin to quietly close off. According to the CDC, more than 60% of all non-traumatic lower limb amputations in the United States occur in people living with diabetes. And the most frightening part? The damage begins long before most people ever receive a serious warning. Dr. Rubio Santner from Metabolic Health Simplified has spent years breaking down exactly where that threshold sits and what your numbers actually mean for your long-term safety. Today, we're going to walk through 8 critical points that every person managing blood sugar needs to understand. And as you'll reach number 4, you may realize why feeling fine is sometimes the most dangerous place to be. So let me ask you this. What was your last fasting blood sugar reading? Drop it in the comments right now, so Dr. Santner can help tailor this science specifically to where you are today. Number 1. There is a particular kind of damage that makes no noise. It sends no sharp warning signal. It doesn't wake you up at night. It doesn't show up as a visible bruise or a swollen joint. It simply erases. And what it erases, gradually and almost imperceptibly, is your ability to feel what is happening to your own body from the ankles down. This is diabetic peripheral neuropathy. And according to the American Diabetes Association, nearly 50% of all people living with diabetes will develop some form of it during their lifetime. That's not a rare complication. That is effectively a coin flip. And the mechanism behind it is directly tied to something most people think they understand: blood sugar. But most people are only tracking in one dimension. Here is what is actually happening at the cellular level. Explained simply, your peripheral nerves, the long, delicate fibers that run from your spinal cord all the way down to the tips of your toes, rely on a steady, clean fuel supply to function. When blood glucose stays chronically elevated, even at levels that don't feel dramatic, it begins triggering a process called oxidative stress inside those nerve cells. Think of it like a slow electrical fire burning through a cable from the inside. The outer protective coating of the nerve, called the myelin sheath, begins to degrade. Signals slow down, then they weaken, then, in some fibers, they stop altogether. Now pause right here for a second, because this is the part most people miss entirely. This process does not require a blood sugar of 400. Clinical data from the ADA indicates that sustained glucose levels consistently above 140 milligrams per deciliter after meals, levels many people consider only mildly elevated, can begin initiating measurable nerve stress over time. The threshold is lower than almost anyone expects, and here is what makes this particularly dangerous for someone in the 50 to 75 age range. As we age, our baseline nerve conduction naturally slows. That means the margin of protection is already thinner. Chronic glucose elevation doesn't have to work as hard or as long to push an older nervous system across the threshold into functional impairment. The result is a person who steps on a sharp object, develops a small wound on the bottom of their foot, and genuinely does not feel it. Not because they are distracted, not because they are not paying attention, but because the biological alarm system that should have fired simply no longer can. That is how the pathway to amputation begins, not with a dramatic event, with silence. Number 2, most people who walk into a doctor's office get handed 2 numbers, a fasting glucose reading and an A1C percentage. And for the majority of patients, those 2 numbers come with a very simple interpretation: either you're fine, you're borderline, or you're diabetic. What rarely gets explained in that short appointment is what those numbers are actually doing to the inside of your blood vessels at each stage along that spectrum. And that gap in communication may be one of the most consequential oversights in routine metabolic care today. Let's start with fasting glucose. The CDC classifies a fasting blood sugar reading between 100 and 125 milligrams per deciliter as prediabetes. A reading at or above 126 on two separate occasions meets the clinical threshold for a type 2 diabetes diagnosis. But here is what those clean category lines don't tell you. Vascular stress, the kind that affects the small and medium arteries supplying your legs and feet, does not wait politely for a diagnosis label to be assigned. Clinical models tracked by the Mayo Clinic suggest that the arterial environment begins shifting meaningfully as fasting glucose moves into the upper prediabetes range, particularly when paired with elevated post-meal spikes that never fully resolve. Think of your blood vessels like a garden hose that was designed to carry smooth, clean water. Now imagine pumping a slightly thickened, stickier fluid through that hose, day after day, for years. The inner lining of the hose, in your body, this is called the endothelium, begins to stiffen, small deposits accumulate, the diameter of the passage narrows, and the organs and tissues at the far end of that hose, your feet, your toes, the skin on your lower legs, begin receiving less of what they need to stay healthy and repair themselves. Now here is where the A1C number enters the picture with far more weight than most people assign to it. An A1C of 7% is often described as controlled diabetes. And in isolation, that framing sounds reassuring. But Mayo Clinic data patterns indicate that patients consistently operating with an A1C between 7% and 8% carry a measurably elevated risk profile for peripheral arterial disease compared to those maintaining levels closer to 6% or below. Each full percentage point of sustained A1C elevation represents roughly 3 additional months of continuous vascular exposure to elevated glucose, and that exposure compounds quietly over years. What this means practically is that the risk of amputation does not begin at the moment of a dramatic glucose crisis. It begins accumulating in the background during what many people describe as their managed years. The years when numbers were high enough to do damage, but low enough to feel like things were under control. That distinction between managed and protected is one of the most important metabolic conversations you can have with your care team. And Chapter 3 is going to show you exactly what happens when that background damage finally meets an open wound. Number 3. Picture this. A small blister forms on the back of the heel from a slightly ill-fitting shoe. For most people, that blister heals in 3 to 5 days. The body dispatches its repair crew. White blood cells rush in, new tissue begins forming, the skin closes over cleanly. It is a biological process so automatic and so efficient that most people never give it a second thought. But for someone whose blood sugar has been running elevated for an extended period, that same blister can become something else entirely. Something that resists every attempt the body makes to close it. Something that deepens. Something that, if left undetected, and remember what we covered in Chapter 1 about lost sensation, can quietly progress into a wound that threatens the limb itself. This is the diabetic foot ulcer. And according to Johns Hopkins Medicine, approximately 15% of all people living with diabetes will develop a foot ulcer at some point in their lifetime. Of those cases, data patterns suggest that a significant proportion will ultimately contribute to a lower extremity amputation if the wound does not receive timely, appropriate intervention. These are not rare edge cases. These are outcomes unfolding right now in the lives of people who started with something as ordinary as a shoe that rubbed wrong. So what is actually breaking down inside the wound environment? There are 2 simultaneous failures occurring, and understanding both of them is critical. The first is circulatory. When glucose remains chronically elevated, the small blood vessels, the capillaries and arterioles that form the fine delivery network reaching every square centimeter of skin, become structurally compromised. Their walls thicken. Their flexibility decreases. Blood flow slows. And since wound healing is an intensely oxygen-dependent process, a wound sitting in tissue that is receiving diminished circulation is essentially being asked to rebuild itself without adequate supplies. It is like trying to construct a building while the delivery trucks can only get halfway to the site. The second failure is immune. Elevated glucose directly impairs the function of neutrophils, the frontline white blood cells responsible for clearing bacteria from a wound site. Johns Hopkins research models indicate that in a high-glucose environment, these cells lose a meaningful portion of their ability to identify, pursue, and neutralize bacterial threats. This means that a wound which would be a minor, self-resolving event in a metabolically healthy person becomes a prolonged, infection-prone battleground in someone whose blood sugar remains poorly regulated. Now, combine those two failures, restricted circulation and impaired immune response, and you begin to understand why diabetic foot ulcers are classified as medical emergencies that demand immediate attention, not a wait-and-see approach. The tissue that does not receive enough oxygen dies. Dead tissue, called necrosis, cannot be revived by medication or nutrition. And when necrosis spreads beyond the point that surgical cleaning can address, the clinical decision shifts towards something far more irreversible. This is not a distant, abstract risk. It is a biological chain reaction, and it is one that begins far earlier in the glucose timeline than most people realize, which is exactly what Chapter 4 is going to confront head-on. Number 4. There is a phrase that appears with striking regularity in the medical histories of patients who ultimately face serious diabetic limb complications. It shows up in appointment notes, in patient interviews, in the accounts families give after the fact. And that phrase is this: "But I felt completely fine." Not, "I ignored the warning signs." Not, "I knew something was wrong but didn't act." Just, fine. No signal, no alarm, no indication whatsoever that anything serious was developing beneath the surface. And here is the deeply uncomfortable truth that Harvard Medical School research patterns have helped clarify over decades of studying diabetic neuropathy progression. Feeling fine is not the same as being safe. In fact, for a specific subset of people managing elevated blood sugar over long periods, the absence of pain is not a reassuring sign. It is a clinical warning in disguise. Here is why. In the early stages of peripheral neuropathy, the nerve damage we walked through in Chapter 1, many patients actually experience uncomfortable sensations. Tingling, burning, a pins and needles feeling in the feet at night. These symptoms, while unpleasant, are actually the nervous system still trying to communicate. The nerve fibers are damaged, but they are still firing, still sending distorted signals, still present enough to generate sensation, even if that sensation is abnormal. But as neuropathy advances into its later stages, something shifts. The nerve fibers that were generating those uncomfortable sensations begin to fail more completely, and when they fail, the tingling stops, the burning resolves, the nighttime discomfort that was keeping someone awake simply disappears. And for many people, that disappearance feels like improvement. It feels like their condition has stabilized, or even gotten better. It has not gotten better. The alarm system has gone offline. Harvard Medical School clinical observations note that this transition from symptomatic neuropathy to what is termed painless or silent neuropathy represents one of the most functionally dangerous phases of diabetic nerve disease. Because at this stage, the protective pain response that would normally alert a person to injury, pressure, heat, or infection in the lower extremities is no longer reliably operational. A person can walk on a fractured bone in their foot, a condition called Charcot foot, without feeling significant pain. They can develop a deep tissue infection beneath intact-looking skin and feel nothing acute enough to prompt concern. Now pause right here for a second, because this point carries real weight. The "I feel fine" trap is not a failure of attention or intelligence. It is a physiological ambush. The very mechanism designed to protect you has been quietly dismantled by years of glucose exposure, and nothing in your conscious experience tells you that has happened. This is precisely why clinical guidelines emphasize that people managing diabetes or long-term prediabetes cannot rely on symptom-driven awareness alone to protect their lower limbs. Waiting to feel something before acting is, in this specific context, a strategy that the biology of advanced neuropathy is designed to defeat. The good news, and there is genuinely meaningful good news coming, is that this biological progression is not a one-way door for everyone. There is a window, there are numbers, there are specific targets that clinical evidence associates with slowing this process and in some cases supporting partial recovery of nerve function. That is exactly where we are headed in Chapter 5. Number 5. Everything we have covered so far, the silent nerve damage, the vascular narrowing, the wounds that resist healing, the disappearance of protective sensation. It would be easy to hear all of that and conclude that this is simply a story about inevitable decline. That once the process begins, the outcome is fixed. But that conclusion would be both medically inaccurate and, frankly, an injustice to the genuine and substantial body of evidence showing that the human metabolic system retains a meaningful capacity for recovery, provided the right conditions are established early enough and maintained consistently enough. There is a window. And understanding where that window sits in actual concrete glucose numbers may be the most important thing you take away from this entire video. Let's start with what the research tells us about nerve tissue specifically. A landmark series of clinical observations published in The Lancet, one of the world's most respected peer-reviewed medical journals, has contributed to a growing body of evidence suggesting that early-stage diabetic peripheral neuropathy is not uniformly irreversible. When glucose levels are brought into a sustained, stable range and kept there over an extended period, some patients demonstrate measurable improvements in nerve conduction velocity, meaning the speed and strength of nerve signal transmission begins to recover. Not in every case, not overnight. But the biological potential for partial restoration exists in a way that was not fully appreciated even 2 decades ago. Now, what does sustained, stable range actually mean in numbers? This is where the American Diabetes Association's clinical targets become directly relevant to your daily life. The ADA's evidence-based framework identifies a fasting glucose target of between 80 and 130 milligrams per deciliter for most adults managing diabetes, paired with a post-meal glucose target of below 180 milligrams per deciliter at the 2-hour mark. These are not arbitrary comfort zones. They represent the glucose environment in which vascular endothelial cells, the inner lining of your blood vessels, experience the least oxidative stress, and in which the immune system's wound response capabilities are best preserved. Think of it this way. Your circulatory system and your nervous system are both extraordinarily adaptive. They did not deteriorate overnight, and the biological signals that govern repair and maintenance do not simply switch off permanently at a certain age or a certain diagnosis. What they require is a sustained change in the internal environment, a consistent reduction in the glucose pressure they have been operating under, before the repair mechanisms can begin outpacing the damage mechanisms. Here is a critical nuance that the Lancet research patterns help illuminate. The window for meaningful recovery appears to be most accessible in the earlier stages of nerve and vascular involvement, patients who brought their glucose into a consistently healthy range while neuropathy was still in its symptomatic phase. The tingling, the burning we discussed in Chapter 4 showed more favorable outcomes than those who achieved glucose control only after entering the painless stage. This does not mean that later intervention is without value. It means that earlier action carries a measurably larger biological dividend. For someone in the 50 to 75 age range, this is not discouraging. It is clarifying. It defines the urgency not as panic, but as precise, informed timing. The biology is still responsive. The window is still open. The question is simply what you do next, and how consistently you do it. Which brings us directly to the specific daily numbers and targets that clinical evidence associates with long-term limb and vascular protection. And that is exactly what Chapter 6 is going to lay out for you in practical, actionable detail. Number 6. There is a shift that happens in the way people think about blood sugar management once they truly understand what the numbers mean. Not just as diagnostic labels, but as real-time biological signals, telling you exactly what your vascular and nervous system are experiencing at any given moment. Most people check their fasting glucose in the morning, see a number, and consider their blood sugar managed for the day. And then they go about their lives, eating, moving, resting, while their glucose climbs and falls in patterns they have never actually observed. Patterns that, according to the American Diabetes Association, may matter far more for long-term vascular and nerve health than that single morning reading ever could. The concept the ADA places increasing clinical emphasis on is something called postprandial glucose, which simply means your blood sugar level after eating. Specifically, the 2-hour post-meal reading. And the target the ADA identifies for most adults managing diabetes is below 180 milligrams per deciliter at that 2-hour mark. For those in the pre-diabetes range or working toward tighter metabolic control, many clinicians aim for post-meal readings closer to 140 milligrams per deciliter or below, a threshold that aligns with the glucose environment in which vascular inflammation markers tend to remain most stable. Now here is why that 2-hour window carries such outsized importance for limb preservation specifically. Every time blood glucose rises sharply after a meal, a pattern clinicians refer to as a post-meal spike, the endothelial cells lining your blood vessels experience a burst of oxidative stress. Think of it like a pressure surge running through a pipe system that was already showing signs of wear. One surge does not collapse the system, but multiple surges occurring 2, 3, sometimes 4 times a day, every single day, across months and years, that cumulative pressure is what gradually narrows the arterial passages, supplying your lower legs and feet with the oxygen-rich blood they depend on for tissue repair and immune defense. The ADA's clinical data patterns make a particularly important distinction here between average glucose control and spike control. A person can maintain a technically acceptable A1C, that 3-month average we discussed in Chapter 2, while still experiencing significant daily post-meal spikes that their average simply absorbs and obscures. The average looks fine. But inside the blood vessels of the lower extremities, the repeated inflammatory surges are quietly accumulating their toll. So what does protecting yourself look like on a practical, day-to-day level? It means shifting some of your monitoring attention away from the single fasting number and toward what happens in the 90 minutes to 2 hours after your largest meals. It means recognizing that the composition of those meals, not just their total carbohydrate content, but the sequence in which foods are eaten, the presence of fiber and protein as glucose buffers, the timing of any physical movement afterward, all of these factors directly influence how high and how fast that post-meal curve rises. Clinical models tracked by the American Diabetes Association consistently indicate that patients who actively manage post-meal glucose, keeping those 2-hour readings below the 180 threshold and ideally trending toward 140, show more favorable long-term peripheral vascular profiles than those focusing exclusively on fasting numbers alone. This is not about perfection. It is not about achieving a flawless glucose curve every single day. It is about understanding which number, tracked at which moment, gives you the most meaningful real-time window into the vascular environment your feet and legs are living in, and then using that information to make small, consistent, compounding adjustments. And one of the most powerful and underutilized tools for keeping that post-meal number in a protective range requires no medication, no equipment, and no special preparation. It takes approximately 3 minutes to learn, and Chapter 7 is going to walk you through it right now. Number 7. Here's something most people don't realize. The most powerful tool for preventing a diabetic foot wound from becoming a serious emergency isn't a medication, surgery, or expensive test. It's a simple 3-minute foot check you can do yourself every day. According to Mayo Clinic, daily foot inspection is one of the most important parts of diabetic foot care because small problems can become major complications before you ever feel pain. The best time to check is in the evening after a shower. In good lighting, look for 5 things: redness or swelling, cuts or blisters, skin changes between the toes, nail problems, and areas of dryness, cracking, or unusual warmth. One warning sign many people miss is temperature difference. If one foot feels noticeably warmer than the other, it could signal inflammation or infection before a wound is even visible. And here's the key: if you notice a new cut, blister, redness, or swelling that isn't clearly improving within 24 hours, contact your healthcare provider. Don't wait a week hoping it will heal on its own. This simple 3-minute habit costs nothing, requires no prescription, and can help catch problems while they're still easy to treat. In the final chapter, we'll bring everything together into a practical, evidence-backed plan for protecting your circulation, lowering vascular risk, and keeping your feet healthy for the long term. Number 8. Everything we've covered today points to one powerful truth: your metabolic future is not fixed. Your body responds to the choices you make every single day, and often faster than most people realize. So instead of focusing on dozens of changes, focus on 5 evidence-backed habits that can make the biggest difference. First, take a 10 to 15-minute walk after meals. This helps your muscles pull glucose directly from the bloodstream, reducing harmful blood sugar spikes. Second, change the order of your meals. Vegetables first, protein and healthy fats second, and starches last. The same foods, in a smarter sequence, can lead to a steadier glucose response. Third, prioritize sleep. Poor sleep increases stress hormones and makes blood sugar harder to control before the day even begins. Fourth, stay consistently hydrated. Even mild dehydration can push glucose levels higher and place extra strain on your system. And fifth, manage stress. Chronic stress keeps blood sugar elevated and makes every other healthy habit less effective. The good news? None of these strategies require perfection. They require consistency. Your biology is listening every day. Every walk, every meal, every night of quality sleep sends a signal. And the evidence is clear. It's never too late to start sending better ones. Everything we covered today comes down to one simple truth. Your blood sugar levels directly shape the health of your nerves, blood vessels, and feet. The damage often begins silently, long before symptoms appear. But prevention doesn't require perfection. It requires consistency. Daily foot checks, regular movement, smarter food choices, and understanding both fasting and post-meal glucose numbers can make a real difference. You now have the knowledge, the numbers, and the opportunity to take action. I'm Dr. Rubio Santner from Metabolic Health Simplified. Our goal is simple: to bring you clear, practical, evidence-based guidance that helps protect your health and independence for years to come. If you found this video helpful, consider subscribing for more straightforward metabolic health insights every week. And before you go, watch our next video on the 5 breakfast foods that cause the biggest blood sugar spikes and the simple evidence-based swaps that can help keep your glucose under control. It's on your screen now.